Now, de novo heart failure patients' admissions are an escalating challenge. When you look at the global report for heart failure registry of patients hospitalized for heart failure, 43% is the proportion of overall patients who were de novo HFrEF, with rates ranging from 20% in North America to 79% in Southeast Asia. In another study, 66% of patients had newly diagnosed HFrEF. Is there a role of ARNI when you have a patient with de novo heart failure and you're starting them on ARNI immediately during hospitalization? Yes, there is a huge role. There is a significant lowering of composite cardiovascular death or rehospitalization for heart failure in these de novo hospitalized patients with HFrEF. When you look at the transition study, that is initiation of sacubitril valsartan shortly after the hospitalization for acute decompensated heart failure in patients with newly diagnosed or de novo heart failure, there was a study which had a primary endpoint to assess the tolerability of treatment as a proportion of patients who achieved the target dose of 97 and 103 milligrams BID at the end of week 10 after randomization. So the point here is any patient with acute decompensated heart failure, are they able to tolerate an ARNI when you start them prior to discharge? That is what the primary endpoint was. The secondary endpoint was initiating ARNI shortly after hospitalization in newly diagnosed de novo heart failure patients, and the proportion of patients who received and maintained any dose of sacubitril valsartan for more than 2 weeks leading up to week 10. Now, when we look at the echographic parameters in de novo heart failure patients, ARNI has a very crucial role in improving cardiac remodeling as well as pump function, and it was much more effective when you compare it to ACE inhibitor or ARB in de novo hospitalized patients with heart failure with reduced ejection fraction. Also, when you look at the HSTNT concentration in de novo hospitalized patients, there was a significant reduction in the troponin concentration with sacubitril valsartan in this group. And more de novo than prior heart failure reduced ejection fraction were able to achieve the target dose at week 10, that is 56% as compared to 45%. So that we are able to initiate the ARNI after the patient is, before the patient gets discharged at the time of ADHF, and within the week 10, that means within 2.5 months, we are able to achieve a target of 100 milligrams PID of ARNI. The earlier you start ARNI, the earlier you start guideline directed medical therapy, we'll be able to have reverse remodeling of our patients within 28 days. SGLT2 inhibitors are able to have cardiac remodeling within 28 days of starting of the molecule. So the earlier we start the molecule, the more benefit we'll be able to get our patients. And when you look at the transition study results, the first line initiation of sacubitril valsartan in de novo HFrEF patients alongside with the initiation of other guideline directed medical therapies is feasible and is associated with a better risk benefit profile than in patients with prior HFrEF. So early intervention of ARNI should be done, and we should be able to initiate this so that we can delay the progression of the patients and prevent the hospitalizations for heart failure. The 2021 update as compared to the 2017 ACC experts consensus decision, when you look at this, what is the treatment algorithm? The treatment algorithm clearly states that ARNI is the preferred choice as a foundational therapy along with beta blocker and diuretic. And because of new evidence, ARNI is now also recommended in newly diagnosed and ACE and ARB naive patients. So able to start this as a first line. So having an ARNI on board, having a beta blocker on board, an SGLT2 and an MRA on board, rapid sequencing should be initiated so that within the first 3 weeks to 1 month of starting heart failure treatment, all the 4 molecules should be on board as per the optimal dosage, and clinicians should aim to achieve optimal guideline directed medical therapy within 3 to 6 months of an initial diagnosis of each. So this is the same. ARNI may be considered as a first line therapy instead of ACE inhibitor in your HFrEF patients. When you look at the HFrEF management, the 2022 guidelines clearly state that in patients with heart failure with reduced ejection fraction and NYHA class 2 or 3 symptoms, the use of ARNI is recommended to reduce morbidity and mortality. Also, when do we use ACE inhibitors instead of ARNI? When there is a contraindication for ARNI. And if the patient is unable or intolerant to ACE inhibitors or an ARNI, then only we should consider an ARB. This is the class 1A recommendation.